Good afternoon, good evening, and maybe even good morning. And thank you for taking the time to join us today for the launch of our Oxygen Assist module. We have an audience today from across Europe, the Middle East, Africa, and Asia Pacific. My name's Simon. I'm the Sales Director from Vapotherm UK. We have two great presentations today from Vapotherm's Ron Fantl and Dr. Kevin Ives from John Radcliffe, Oxford. During these presentations, you will learn about the technology and the clinical experiences using Vapotherm Oxygen Assist module. If you have any questions during the webinar, feel free to enter them in the questions function on the right-hand side of the screen, and we've put time aside to answer them at the very end of the webinar. Yeah, feel free to ask any questions you like. It's my great pleasure to welcome you onto this webinar and be part of our full market release of the Oxygen Assist module. You may already know a little bit about the Vapotherm Oxygen Assist module. I'm not going to steal any of Ron or Dr. Ives' thunder, but this technology is really going to have a positive effect on patient outcome and support the staff in your unit to care more efficiently for your patients. If you can take a moment to read the disclaimer on the screen at the moment, we'll have a few questions at the end from our lawyers. So on to our speakers. We have Ron and Dr. Kevin Ives. So Ron is our international medical education leader. He trained in Germany as a nurse, ICU practitioner, and respiratory therapist. This cumulative 7 years of medical school has been combined with 20 years clinical experience in the University of Heidelberg. In his last clinical role, he was in charge of the Heidelberg Center of Mechanical Ventilation and Respiratory Support, and was exposed to all kinds of respiratory technology such as ECMO, mechanical ventilation, NIPPV, and obviously high flow, as well as high velocity therapy in different patient populations. And our second speaker is Dr. Kevin Ives. He trained in Cambridge, London, and Brighton. He's been a consultant neonatologist in Oxford since 1991. Kevin was a member of the team that placed the first baby in the UK on nasal high-flow therapy in November 2004. He's been an outspoken evangelist for this form of non-invasive respiratory support ever since, receiving invitations from Europe and the USA to share his experience and enthusiasm. He was a contributing author in an international consensus document on the use of nasal high-flow therapy in neonatology 2017, and in recent years he has collaborated with Peter Reynolds on a randomized crossover study of automated oxygen control for preterm infants receiving nasal high flow in 2018. He has been involved, along with some small number of other UK centres, in evaluating the next generation of Oxygen Assist module, and is here to share his experiences with us today. So without further ado, I will pass you on to our first speaker and let you take it from there. So thank you very much, and we'll join up at the end of the webinar. There you go, Ron.
Thank you very much, Simon, for your kind introduction, and thank you very much, everybody on the call, for joining this call. It's a real pleasure to be part of today's webinar, and I sincerely hope that you will enjoy it. You will have some fun, but also some learnings. And as Simon already mentioned, please feel free to post all your questions during both talks, Dr. Ives' talk and my own talk. Especially myself, we are not very multitasking able, so please don't take it bad if we will answer the question right at the end of the presentation. The Oxygen Assist module is a closed loop controller to automatically titrate the FiO2 on your Vapotherm high velocity device. You as a clinician, you decide on the desired SpO2 target value. So you choose which SpO2 target you want to target for your patient. The module uses built-in pulse oximetry to measure the SpO2, and this is not a OAM-owned technology. You can get the Oxygen Assist module either with Nalcor or with Masimo built-in technology. And based on those two parameters, so your set SpO2 target and the measured pulse oximetry of the baby, the Oxygen Assist module decides every 10 seconds whether or not to increase or decrease the FiO2 on your precision flow. automated oxygen control is not really a brand new idea. Already back in 1979, the first publication originating in the Hammersmith Hospital in the beautiful city of London looked into a servo control unit based on an umbilical arterial catheter in preterm born infants. It was a pretty massive setup with a really ancient technology and a huge computer continuously monitoring the umbilical arterial oxygen saturation and adjusting the FiO2 of the babies delivered via a head box in those days. And as you can imagine, those old English professors, they were a little bit more concerned than people today. So they looked into the time outside the range, comparing automated control to manual control. Today, we would look at it a little bit more positive and would investigate the time within range. But in fact, there's obviously no difference. And their results already these many years back were already overwhelmingly pointing towards the benefits of servo control. The babies in the servo control arms spent approximately twice the amount of time within the desired target range than the babies in manual, let's say, in nurse control. If you compare the absolute resulting numbers to the numbers we see in trials today, it seems that in those days, the technology was more effective and the nurses were as well. I think this is a misinterpretation. I think we need to consider and we need to recognize that the preterm babies that were enrolled in these trials in those early days were by far not as preterm and were by far more mature than babies that are enrolled into trials today. A little bit more modern trial is the Intello2 trial out of 2 centers in the United Kingdom, published by Peter Reynolds and Dr. Ives, who you are going to meet in a couple of seconds. It's going to be a couple of minutes again. They looked into the performance of the Intello2 device, and to complete the confusion today, Intello2 was the name of the prototype of the oxygen assist module. So the hardware changed since the study. The algorithm that works and the algorithm that keeps the patients or tries to keep the patients in target range is unchanged. So the Intello2 trial results are the results that you would most likely see using the oxygen assist module today. It was a multicentric, a bicentric, randomized controlled trial. It was a crossover study design with 30 babies. Every baby was its own control group, and every baby was treated 24 hours in manual control and 24 hours in automated control. The randomization was focusing on whether to start in manual and transition to auto or the other way around. There was a couple of outcome parameters that the investigators looked at, whereas the main outcome parameter, so the primary outcome, was time within target range. The target range for the study was an SpO2 of 90 to 95. Nurses in the manual arm were instructed to keep the babies as good as possible between the sets of 90 and 95. The Intello2 device, or the oxygen assist module, uses a single SpO2 target value, and the SpO2 target value was set to 93 because 92.5 simply is not available in the technology. And if we look at the primary outcome parameters, the automated controller, so the oxygen assist module, was significantly more effective in keeping babies within this desired SpO2 target of 90 to 95. The controller achieved 80% time in target range, whereas manual control, which was nurse control, achieved 49% only. I just want to focus on this number of 49% because this may seem a very bad result for well-trained nurses, but by far it's not a bad result. If you look into many, many studies that are investigating time in range using manual control, all these studies usually result in approximately 45 to 55% time in target range achieved by manual, so by nurse or respiratory therapist control. And this is not that these clinicians are not capable of achieving a higher target range. The reason simply is that those preterm babies are prone to severe fluctuations in their SpO2, and it's simply extremely challenging to keep them in target range. So to make a long story short, these 49% are actually an excellent result, but the computer, so the closed loop controller, still achieves approximately 30% more time in target range. Secondary outcome parameters were time above and time below target range. And in both, let's focus first on time below target range. Also, the time below target range was significantly shorter in automated control than it was in manual control. And the number of hypoxemic incidents also were lower in the automated group compared to the manual group. And if we look at the right end of the x-axis, so the time above target range, also here, the controller, the automated controller, performed significantly better than nurse control. The time above target range, the time in hyperoxia, was significantly shorter in automated control than in manual control. Worth mentioning, though, that the number of hyperoxic incidents was the same comparing manual to automated control. So yes, the controller does overshoot, as well as nurses or manual control would do, but the time after this overshoot, the patients stay above target range, is significantly shorter than in manual control. This is a little bit of a confusing slide, but I want to guide you through this. This is the distribution of FiO2 compared to the time in target range. You can see at the right end of the x-axis that the gray dotted line, which speaks for the automated arm, the controller is not shy to use higher FiO2s than nurses would do, but still for a very, very short period of time. But focusing on the left end of this x-axis, you can see something really amazing. Babies in automated control spend significantly longer at room air than babies in manual control. So the controller is not shy to quickly increase the FiO2 and use for a brief period of time high FiO2s, but at the same time, the controller also is not shy to decrease quickly FiO2 and allow the babies to spend as much time as possible in room air. This is the very important finding for me. The question is, why is the controller so much more effective than manual control? And the answer is not that the controller is more clever than clinicians or nurses would be in maintaining babies in target range. The reason why the controller is so much more effective is simply that the controller doesn't have anything else to do. And this is really nicely shown with this graphic, where you can see that the average number of manual adjustments per hour in the study was 1.6. So on average, nurses adjusted the FiO2 1.6 times per hour. Whereas on the other hand side, the controller adjusted the FiO2 up to 100 times per hour. The controller doesn't have anything else to do than sitting next to the baby, monitoring the SpO2 and adjusting the FiO2 every 10 seconds. And this extreme high activity of the FiO2 controller results in a more stable SpO2. And this is nicely shown on this graph out of the study. You can see on the upper trace is the SpO2 trace of a study baby over 24 hours, and the lower trace is the FiO2 trace. So you see within those 24 hours, the nurses were pretty worksome and they did adjust the oxygen quite often. But if you compare these traces with the same baby on automated control, you can see that the upper SpO2 curves gets a lot more denser as soon as the closed loop controller starts at work. And what the money you pay for it is basically the extreme high activity of the FiO2 controller. You see that the SpO2 noise is reduced by tremendously increasing the noise on the FiO2 curve. So the controller completely runs crazy, increases, decreases, increases, decreases FiO2 all the time. And this basically stabilizes the SpO2 to allow the babies to spend more time in target range. And you will see many more, much more realistic displays of graphs like this in Kevin's presentation in a couple of minutes. So what we basically clinically know today is we know that hyperoxia is associated with a higher risk of ROP and with a higher risk of lung damage. And what we also know is hypoxemia is associated with a higher risk of death, neck, and neurodevelopmental impairment. That's what we basically know. And going back to the study to make this abstract time in, time above, and time below target range a little bit more meaty, time above target range means time in hyperoxia, and time below target range means time in hypoxemia. So the controller reduces time in hypoxemia and it reduces time in hyperoxia. The study, though, was a technical study. We don't know whether it had any impact on clinical outcomes of the babies. This was not a question asked within this study. We don't know anything about the impact of a closed loop controller on clinical outcomes. We don't know anything about the impact of frequent FiO2 fluctuations on the baby. We do know about the impact of SpO2 fluctuations, and we know that they are negative. We also don't know the perfect SpO2 target range today. This still needs to be answered. But what we know is a closed loop controller keeps babies more time in range, less times in hypoxemia, and less time in hyperoxia. So the clinical value of a closed loop controller like the oxygen assist module, it allows you simply to reliably realize your selected SpO2 target. If you feel you know which SpO2 target is beneficial for your baby, if you ask the controller to follow this instruction, it will achieve approximately 80% time in range. If you ask your clinical staff to achieve your SpO2 target, it will achieve approximately 50% time of the set target range. It assists your staff in maintaining the target SpO2, and it also is a great tool to further evaluate all the questions that haven't been answered yet. Now we have the technology available to answer the questions in terms of outcomes, in terms of workflow improvement, and also closely work on the best clinical indications for closed loop controllers. And moreover, more than just keeping babies in target range, it also reduces SpO2 alarms, because simply as soon as the time within the target range increases, the number of hyperoxia as well as hypoxemia alarms decreases. And if you have less alarms, you also have less noise. And if you have less alarms, you occupy nurses less to address the alarm, to adjust the FiO2, and you may release time for care that can be used for much more valuable things than just turning a blue FiO2 knob. Before I get to the end and hand over to Kevin to share some much more exciting information than the stuff that I'm sharing with you, I just want to share 3 important sorts and settings when you're using a closed loop controller like the Oxygen Assist module. First and foremost, the Oxygen Assist module doesn't target a range. The Oxygen Assist module targets a single SpO2 value. Humans always target a range, but we never intended to mimic human behavior with the Oxygen Assist module. We wanted to leverage on all the benefits of a computer. So the Oxygen Assist module uses a SpO2 target value, in this case that you can see on the screen, set to 93, which means as soon as the SpO2 of the baby gets 94, FiO2 will be decreased. As soon as the SpO2 drops to 92, FiO2 will be increased. You can also set, choose, and change your target range. The target range, though, doesn't impact the controller's behavior at all. The target range is really there only for a graphical and visual display of your trends, and Kevin will show you this in more detail in a couple of minutes. The second setting I absolutely want to share with you is an additional monitoring. Using the Oxygen Assist module really requires FiO2 monitoring. You need to set an FiO2 alarm. And you might ask yourself, why an additional alarm? One of the great values of an Oxygen Assist controller is that the babies have less alarms because they spend more time in target range. Why the heck do we add another alarm that might increase the noise on the unit? And I think it's really important to understand that the algorithm, the Oxygen Assist module, is desired to keep your SpO2 in target, and it does a very good job. If the baby slowly deteriorates today without using a closed loop controller, you will get an SpO2 alarm. Nurses will react to the alarm, they will adjust the FiO2, and they recognize and know something is happening to your patient. Using the closed loop controller, the increase in FiO2 can be much quicker than the alarm on your monitor. So as you see in the picture below, or in the graphic below, you can see the SpO2 trace is dead stable. The baby is stable in the SpO2 over the 24 hours. You see a little bit more noise, you see a little bit more noise in the middle of these 24 hours. But especially the last third of those 24 hours, if you look only into the SpO2 trace, looks extremely stable. But if you correlate this with the FiO2 trace, you can see that within the last third of those 24 hours, the mean FiO2 increases. So the baby needs more oxygen to be an SpO2 target, which means something is happening with the baby. And to make sure that you don't miss this deterioration of the baby, this higher oxygen demand, you absolutely need to set an FiO2 alarm limit to be alerted when the mean FiO2 increases compared to what you would expect from your patient. And last but not least, the last value I want to emphasize on is the mean O2. Today, if you want to know how much oxygen needs my patient, you will look onto your precision flow and the FiO2 will tell you, well, my baby needs 28%. That's also the value that you use for your hourly observational documentation. Using a closed loop controller like Oam makes the FiO2 display on your precision flow pretty much useless because the number can change up to 100 times per hour because the controller increases and decreases the FiO2 all the time. So the value to give you the feeling how much FiO2 your patient really needs cannot be taken from the precision flow. That's why you absolutely need to use the mean O2, which is displayed on both the home as well as the trend screen of the Oxygen Assist module, and it represents the average FiO2 delivered within the window that you can see. So usually you would set your home screen to 60 minutes, which means that the mean O2 displayed on your home screen is the average FiO2 that the baby used within the last 60 minutes. Nonetheless, the OAM does not replace SpO2 monitoring. The OAM is not a monitor. The OAM is a closed loop controller to keep your babies in target range. And the SpO2 probe is not covered with alarms. So you absolutely need additional SpO2 monitoring to detect desaturations or hyperoxias that are not caught by the Oxygen Assist module, such as, for example, apneas. So to conclude the first couple of minutes of this webinar today, please note the Oxygen Assist module is not a set and forget system. The Oxygen Assist module is not a self-driving car. I would say the Oxygen Assist module is rather a cruise control. You are in charge of your speed limit. You are in charge of choosing the right SpO2 target. The Oxygen Assist module, though, will help you to keep the babies on the desired speed that you set on the desired SpO2 target. Thank you very much for your attendance. And now quickly over to you, Kevin.
Thank you very much, Ron. I hope you can all hear me. It's Kevin Ives here, based in Oxford, and it's a great pleasure to follow on from Ron's very clear explanation of the technology that's been achieved by Vapotherm over the last 5 to 10 years. So to start with, why have we in Oxford been particularly interested in using this technology? Well, we've always had an interest in oxygen control. Oxford was one of the collaborating centres for the Spo2 trial, headed by Professor Ben Stenson. And oxygen control, as Ron was saying, in that era was very much the nurse's responsibility. And by offsetting saturation monitors, the differentiation between a low saturation target and a higher saturation target was achieved. But now we have automated delivery of high flow. Anybody who knows me realizes that I have a great love affair with nasal high flow therapy, or HFNC, as you may wish to call it. So when Vapotherm have combined automated oxygen delivery with high flow, you can see why I've got a big smile on my face. I'd like to thank Ron for his introductory talk, and actually more personally, I'd like to thank Ron for his commitment to the rolling out of the OAM in Oxford over the last year. It could be said that Ron has spent as much time, if not more time, on my own unit than I have. Also, I'd like to acknowledge very much and pay tribute to the research and development team at Vapotherm. I don't have time to name them all, but there's been tremendous collaboration between Vapotherm and the Oxford unit in both support of the trial, Peter Reynolds' trial that we were collaborators in, and also the ongoing introduction of the OAM. So what am I going to cover in this talk, hopefully in the next half hour? Well, these are the topics. So some of it will be our experience of the Intello2 trial, which Ron has covered to some extent. And then just give you a flavor of our introduction of the Oxygen Assist module and some of the lessons we've learned from that, some of our personal recommendations, the guidelines we're developing, which you may wish to adapt for your own parameters of use, the importance of staff training, which babies to use the OAM on, and whether there are some potential problems and what are the benefits. And then right at the end, I will try and allude to the future of this device in neonatology. So on your units, I don't know what sort of monitors you have, but you may be going around on a ward round. And I can certainly remember in the previous era, we would just really basically have a screen up, which would give you in real time, as I might be able to show you here, just a 10-second clip of what's happening on the unit. And this is just a snapshot, and it's not really giving you much information at all in terms of the stability or otherwise of your patients. You may prefer a system where you've got that real-time monitor and a trend value displayed, as in this case for the preceding 4 hours. And you can see here the saturations are dipping a little bit. There's a bit of tachycardia. So you might read into that something is happening with this baby in the last hour. Or you may wish to interrogate your monitor further. I have a habit of always looking back over the last 24 hours here as displayed, particularly looking at the saturations shown here, the SpO2 shown in blue, ranging between, well, below 80 at times and 100%. You can also use your monitors, and I'm sure you're probably all familiar with this. You may want to analyze that further by looking at a histogram or a cumulative histogram of the percentage of time on the vertical axis that a baby is sitting in the various saturation ranges. And if this is a preterm baby, ideally wanting that baby to be between 90 and 95% saturated. And derived from that previous pattern I showed you, this is a rather miserable 22% in this case. So Ron has kindly gone over the Intello2 trial, as it's sometimes referred to. Peter Reynolds, my good colleague at St. Peter's Hospital, Chertsey, teamed up, and we put this trial together. This was our first baby in the trial on the 10th of May, 2017. And I purposely show a picture of my good colleague, Dr. Hilary Adams, because she was the colleague who, alongside me, put the first baby onto high flow back on our unit in November 2004. In this trial, there were 30 babies, and 18 of them were from Oxford. And I personally spoke to all the parents to get the consent prior to enrollment. Now, consent often involves pages of paper information for parents, but I'm a rather simple guy, and I found a pictorial representation which I provided for the parents, a much simpler way to explain what we were trying to achieve in the Intello2 trial, taking them down this side of the image to show the normal nursing care with a nurse observing the saturation pattern and manually changing the delivered oxygen. Now, the key thing to appreciate in the trial and in the ongoing use of the OAM is there has to be a second pulse oximeter on the baby, which is delivering information to the OAM, and the OAM is then, through its algorithm, moderating the percentage oxygen delivery. And in the case of our trial, we had 24 hours of either auto or 24 hours of manual control. And we emphasized to the parents that the nurse could override the feedback at any time if she required to. But as Ron pointed out, this is a very rare instance that manual alteration of the delivered oxygen was necessary in babies who were under servo control. So what do we see on the screen of the OAM? I'll try and demonstrate here. This is the display on the home screen. And here this is just 2 minutes running along in real time. We're on auto. We've got a target of 93. Here's the range. You see 91 to 95 is what we're using as the range. This is the backup oxygen alarm limit, which is denoted by this dotted red line here. And as you see, the baby, the saturation shown here, saturation values, and oxygen delivery shown here in green, oxygen values. The baby is comfortable here and then has a desaturation. And the OAM responds by delivering more oxygen, and the baby returns back up to our target range. But then there's a further desaturation, and I'll just run this if I can, just to show you what's happening in real time on this monitor. So you see there continues to be a desaturation. We're seeing it going down to 85, 86, and then the OAM responds by delivering more oxygen. The SpO2 returns to the target range, and there's a further adjustment to prevent the SpO2 overshooting, which will be the end of this little sequence here. I'll show you another example. I put this still image in just in case the video didn't function, but you see here the same sort of thing. We've got decreasing saturation, desaturation, delivered FiO2, and recovery in the saturation back into this normal range. Ron was explaining how active the OAM can be in responding to the SpO2. I show this example. This is a 15-minute trend screen with the saturations running here. And I've personally counted the number of changes. There are 70 changes in oxygen delivery occurring over these 15 minutes. So what did we see in the Intello2 trial? This is an example of a 24-hour trace, and in manual you have rather erratic saturation trace. Switching to auto, you could see the transition immediately in tightening up the saturation values. And then looking at the cumulative histogram that I introduced you to before, percentage of time in the saturation ranges, you see on manual this was 39%. And also what you should see is the tail off with quite a number of occurrences of saturations below 85%. Switching to auto, in this case, we achieved 73%, and importantly, far fewer desaturations or far fewer episodes of hypoxia and far fewer episodes of hyperoxia. So with that background of having conducted the trial, with many of our nurses coming on board and becoming familiar with using the device, we did have a gap between the trial and then rolling out the new version, the OAM. And so it was very necessary to reinforce teaching. Now you might think something's gone wrong with that slide, or you might think I'm trying to test your eyesight, but I'm just reminding you that teaching is so very important. And we have Ron here. You can tell by the delivery of his presentation, he's a very clear educator. And we have also Stephen Drazy, who works for Vapotherm, who's done a lot of work educating all our nurses and as many of the junior doctors as possible. So I cannot emphasize enough that people have to understand how the module works. What we've developed, and this is an earlier draft of it hanging up on the stand for the OAM, is a cot-side guidance for the use of the Oxygen Assist module. And Ron's already taken you through this, so I'm not going to reiterate it. But moving on from that, we need to then, whilst running the module on manual for an hour at least, just observe how closely the two SpO2 values are correlating. So the value produced on the OAM and your value on your monitor. And only if they are satisfactory in their correlation should you switch to auto. Ron has mentioned this, that we're asking our nursing staff to record hourly the mean O2 and also to observe whether that correlation is maintained. It's important, as Ron was emphasizing, not to be over enthusiastic or encouraged by the fact that the saturation trend stays in a nice comfortable range. You need still to be observing whether or not the baby is deteriorating in terms of the requirement for oxygen. So no longer do desaturations bear a useful indication of the stability or instability of your patient. Peter Reynolds and co-writers of our paper did emphasize this. It was one of the last sentences in the paper, and I'll read that out to you. If automated devices are to be routinely introduced, alternative indicators of clinical deterioration must be robust to prevent false reassurance provided by the stable SpO2 signal. I'll try and give you examples of that as we go along. Moving on to patient choice, which babies should we be placing on the OAM device? And you'll probably immediately be drawn to this baby on the bottom trace here. And our setup in Oxford for such a baby would be to place the backup oxygen at the current FiO2, the oxygen alarm limit 10% above that value, the target range for preterms 93%, for term babies 96%, and our target range set on the OAM is 91 to 95, as it is on our devices, on our monitoring devices, and we adopt a alarm limit on our monitoring devices, 1% either side of that. I realize that many of you will have different ranges that you use, and so I would suggest that you adapt these values to your own parameters. Ron's already taken us through this home screen, and what I'm trying to emphasize here is assessing the saturation level you're getting when running on manual and seeing whether it's tallying with your device, because the difference between the patient monitor and the OAM should not be more than 3%. And that's when the baby is settled. If this is not achieved, consider changing your probe position, or you may even need to change the probe entirely. I'll come back to some other tips and recommendations for making sure that this saturation SpO2 correlation is achieved. So here we are. Of course, I'm going to take a photograph of one that's behaving absolutely perfectly, 97, 97. But that's ideally what you're wanting to see, the two correlating well. So this is a trace. We're back on a trend screen here. This is 60 minutes an hour. And we're coming towards transferring a baby from manual to auto. You can see this is manual because the nurse looking after the baby has just made one change in the oxygen delivery. When you switch to auto, the oxygen upper limit is indicated and the device starts its active function of aiming to keep the SpO2 within the target range and actually trying to achieve 93%. I'm just going to quickly show you some of the other screen variants. So you've seen a 2-minute home screen, the one I showed you with the active video. You may want to adopt a 15-minute screen, the one I showed you with the 70 manipulations in FiO2. Our preference has been to tend to leave as a default the 1-hour screen. This is useful because you can see trends in oxygen delivery. This baby is relatively stable here. You can see your target and you can see whether the SpO2 is performing well. When you switch to the trend screen, however, you get all of that information, but in addition, you get this figure, which is giving you both the mean O2, which is on the other screens, but also the percentage of time in range. And that's another useful thing to be monitoring over time. You can trend the time value from 4, 8, 12, 24, or 72 hours. What I'm showing you on this screen is a 72-hour trend screen. And I'd like to suggest that if you look from left to right on here, that this baby is gradually improving. So for this 24 hours, there's quite a lot of activity of the OAM. The middle 24 hours, the baby is calming down a bit, and this period, the baby is very much improved. This looks to me like a change in saturation probe rather than a significant desaturation, because the OAM would have responded with oxygen delivery. So over time, you can see a baby improving. You can also see a different activity states, sleep patterns, affecting the pattern of stability of the SpO2 signal. This was a case in point where I was looking at a 60-minute home trend, and this baby isn't in much oxygen, and particularly when prone and asleep, is happily going along like this. And then when the baby is awake, or perhaps is being handled, there's a more active period. Here's another example. I think, in fact, Ron showed you from the paper that we published, a pattern a bit like this, but over a 24-hour period. What I'm showing you here is an 8-hour trend. And what you're seeing here is a fairly stable baby, but who in the last couple of hours is showing increase in oxygen requirement. The oxygen limit has been reset a bit higher, but still it is alarming to indicate to the user that this baby's oxygen is going up, and this alarm comes on after 2 minutes of the oxygen delivery being above your set value. And you can see further pushes in oxygen to keep stability here. This baby unfortunately had an infection and ended up requiring mechanical ventilation. Another example, what's the explanation for this deterioration? So a very similar pattern, but this is over a 60-minute home screen. You can see this baby's alarm limit has been set at 45. What's been going on? I happened to walk on the unit. This is just 12 days ago, and I asked the person looking after the baby, what's happened here? And what it was this baby had blood tests done at this stage, and rightly or wrongly was left in a supine position. And you see the oxygen requirement had climbed up to about 70%. You may think this baby is heading for mechanical ventilation. So between us, we checked the prongs, they were okay. We put the baby in a prone position, settled the baby, and this is just 15 minutes later, the baby has settled down to the pattern it had before. So this provides a very useful assessment and indication, particularly for the nursing staff, of fluctuations in the stability of the baby. But no longer do you use the fluctuations so much in SpO2, it's fluctuations in delivery of oxygen. Here's another example, whether this was fortuitous or not, but increasing the high flow rate from 6 to 8 liters stabilized this baby, who was over an 8-hour period, so 4 hours to here, had a much more stable saturation trend, and also a less active oxygen delivery from the OAM. Now, earlier on in my talk, you may recall I showed you this slide, and you probably all were drawn to this pattern at the bottom as being the kind of baby who would most benefit from the OAM. Well, let me show you another baby here. This baby was predominantly in air to 24% oxygen. And this is on a manual display of the 60-minute trend. And you can see the saturations here. The baby actually was in 25% oxygen here, and was on a number of occasions reaching 100% SpO2, and only 23% of the time within this range. Switching the baby here to auto, you see that immediately the OAM has brought the baby down to air, and then subsequent to that, when required, gives the baby some additional oxygen. And over a 60-minute trend, the mean oxygen delivery is 22%, and the baby is 94% of the time in range. When a baby is in air, the calculation for in range, as it was in the Intello2 trial, would include values of SpO2 above 95%. Obviously, if you're in air, you can't achieve a lower saturation. So moving on to the messages to take away from our experience, what we're seeing is there are potential challenges. If the oxygen delivery or intake of the baby is interrupted, obviously giving more oxygen is not necessarily going to help. Now, a classic example is if the baby dislodges its prongs. Now, as you see, this baby, for some reason, and I cannot think why, doesn't value the benefits of nasal high-flow therapy. I'll have to have a word with them when they grow up. But obviously, if the prongs are out, you're going to be delivering oxygen into the incubator. A significant apnea, I'll show you an example of that in a moment, can present problems. OAM signal loss, if the saturation probe that you're using to direct and inform the OAM becomes dislodged for 2 minutes, the device reverts back to the manual mode and to the oxygen setting that you've provided as the backup. If, however, the baby has been in more oxygen for the preceding period before that disconnection, the machine will revert to that higher average FiO2. This we have found very rarely occurs. You sometimes get intermittent signal loss with babies who are very active, but we don't have probes falling off. This issue of the discrepancy between the SpO2 of the monitor and the OAM does need to be considered. And I would suggest that sometimes that problem there is that the monitors need to be, saturation probe sensors need to be repositioned. Or you may have to consider whether or not the averaging time of your patient monitor is suitable or analogous to the averaging time of the saturation device within the OAM. Now, the OAM either has a Nellcore device or a Masimo device, and that in itself should correlate with the device you're using. We happen to both be using Nellcore on both. And the averaging time of both of the saturation monitors informing the OAM is 8 seconds. So if your monitor here is set to 20 seconds or 5 seconds, you might find differences in lag between the averaging of the SpO2 signal. We have found that if we put our monitors to 10 seconds averaging, it will help with this correlation. The other indication I put down here was, is this a problem? Right to left ductal flow. We haven't found that a problem. Most of the preterm babies that we have used the OAM on are beyond the period where there's a problem with their ductus or there's purely left to right shunting. I can imagine in say a term baby with moderate meconium aspiration syndrome or pneumonia who's on high flow, who may have a degree of pulmonary hypertension, that there could be an issue if you've got right to left ductal flow or interpulmonary shunting, in which case, if you feel you're getting strange values on your SpO2s, check whether there is an upper to lower saturation difference before considering where you place your SpO2 signal. I haven't come across that problem yet. My response would probably be to put both of the monitors, if I could, both of the sensors pre-ductally. Right, I mentioned apnea being a potential problem. This is a trace from the old Intello2. So it's a similar, here's the saturation wandering down and then taking quite a nosedive, despite the fact that the device is attempting to up the amount of oxygen delivery in this stepwise manner. But it's not until the attentive nurse comes along and provides tactile stimulation, that you get recovery. So babies who are having frequent apneas, you've got to be a little bit more cautious with. I don't regard it as a contraindication to using the OAM because the baby is also on your regular monitoring device, and therefore the nurse will be alerted to these deteriorations. So what about benefits? I see benefits as being particularly for the parents and particularly for the nursing staff. So during the Intello2 study, we noticed that the use of the automated oxygen control reduced the stress and anxiety that parents frequently experience when witnessing fluctuations in their baby's oxygen saturation levels. So it can't be overemphasized how stressful it must be sitting beside your baby with various alarms going off and numbers flashing all the time. Having said that, I also caution any parents where I introduce them to the OAM monitor is you may not be so worried about the saturation values up here that the parents are aware of. What you might get a little bit anxious about is how quickly the oxygen delivery changes on the precision flow. And I think that needs to be explained to parents. It's not a bad thing, but it needs to be explained that it will jump around quite a bit to achieve its aim of getting a more stable SpO2 response. And where I think this technology is particularly helpful for parents is when they have the baby out for skin-to-skin kangaroo care. And the parents are no longer having to crane their neck to look at the saturation monitor or the heart rate monitor. And they're less likely to be interrupted by alarms going off. So I think that's a great advantage. And here's an example of this, of a mother who gave Ron the permission to take this particular photograph. Baby who's on quite a substantial amount of high flow support, 7.5 litres, 39% oxygen. But if your eyesight's good enough, you'll see up here 92% stable saturations here. So that's where I see a great advantage of the OAM. For the nurse, the improved stability of the baby's oxygen saturation level and the reduction in SpO2 alarms allowed for greater attention to be directed towards the family. So perceived benefits of the OAM from our experience to date. I think we see improved stability during nursing cares, handling and weighing. In fact, there's a study from, I think, Peter Dargaville's group in Australia where they've looked at the effect of the stability of an algorithm that they're using on babies when they're having all cares, for instance. But subjectively, just looking at the monitor, you can see that these babies are more stable. It compensated for fluctuations in SpO2 with activity level of the baby, sleep state, prone or supine position. And certainly it reduced the nurse workload in terms of having to alter the FiO2. And this, in our situation, that's particularly the case where we have a 3:1 patient to nurse ratio on our high dependency unit. The OAM also improved the stability during blood sampling, intravenous access, performing lumbar punctures, performing head scans. And as another example, I would suggest during less invasive surfactant administration, the LISA technique, and I'll show you an extreme example of that. Here we have a little baby born in 2019, 24 weeks gestation, 710 grams. This is my good colleague, Dr. Charles Raw, who's demonstrating his skills with video laryngoscopy and putting in the catheter to administer LISA to this baby at 30 minutes of age. And although you can't see it, just to the left of this screen is the OAM, which is delivering 75% oxygen to this baby during the procedure. And again, for those with good eyesight, you see the saturations are 90%. This little baby, same baby, day 10, still on the OAM, having out for a cuddle and going home. And this baby, quite amazingly, never required any CPAP, and it was never ventilated. That's an extreme example, but this would be an approach we would be adopting, certainly for babies of 26 weeks gestation and above. What have we learned about the Oxygen Assist module? Well, as Ron's told you, and from the trial, it keeps the babies in the desired target SpO2 for a greater proportion of the time. It reduces hypoxia and hyperoxia. It reduces nursing workload. And as I hope I've been able to demonstrate with the examples I've given you, it really is a useful source of trend data on ward rounds. So you can just quickly wind back and scroll back all the way through to the start of the period when the baby was put on the OAM. And that could be days or even weeks. And I think for the nursing staff and the doctors, it also provides an early warning of deterioration and also confirmation and reassurance that there's been improvement. I think on my unit, I think it's very popular with the nurses and the parents in particular. And as I would say, it's the future, there's no going back. Just as I said about nasal high flow therapy, I'm saying the same about the combination of nasal high flow therapy and automated oxygen control. Future developments, I think there will be refinements in the algorithms of these devices. We need to think about what's the most suitable patient profile. It's tempting to think of the so-called flip-flopping baby whose SpO2s are jumping up and down. But I think we should also be concentrating on the babies at high risk of ROP, perhaps the babies less than 26 weeks gestation. Ultimately, I think it will become a nursing choice and maybe a parental preference or even a demand. The encouragement we get from the parents is that they will be quite disappointed if they are discharged out of our unit to a step-down unit that doesn't have this technology. So within our area now, one or two of the step-down units are adopting the same technology. And so then we could have a continuum of care from one unit to the other. We're thinking of using it on our Vapotherm transport unit, taking that to delivery room and using it to control the oxygen delivery during the birthday cuddle, which could be prolonged for 5, 10, 15 or more minutes, or maybe, as I was discussing with one of my colleagues yesterday, even the babies, the near-term babies who've got a little bit of respiratory distress, a bit of transient tachypnea of the newborn. This could be a good way of stabilizing those babies for a little while in delivery suite and perhaps preventing their admission to the neonatal unit. There's an ongoing trial in Tübingen headed up by Axel France and Christian Poets, and there'll be 2-year outcomes of a cohort of over 2,000 babies followed up after being on either ventilators or CPAP with automated oxygen control. I'd like to put in a little word for another randomized trial, the Rome study, which is being headed up by Dr. Lal and colleagues in Middlesbrough in the UK. And this is randomizing babies to either have OAM on auto or manual for the duration of their stay on the neonatal unit. And maybe in the future, there will be studies of the best target SpO2. And maybe we should be tempting Professor Benjamin Stenson to be doing the Boost 3 trial in the future. We're not there yet, though, and the accompanying editorial or commentary that went with our paper in Archives was quite thought-provoking about artificial intelligence. We need algorithms that are truly intelligent. Current devices are essentially robotic in function with little ingenuity or intuition. It would certainly benefit from some intelligence of an artificial type. I think that probably could be said for a lot of us, but that's an important point being made by these are key authors in the area of automated oxygen control. So I'll finish up with this is my favorite picture of 2 of our nurses looking after this baby. I think it will become, we have now 8 of these devices on our unit. We should be purchasing a further 8 going up to 16. We have 16 intensive care beds, 18 high dependency beds. And I foresee the future where it's a nursing decision as to whether they use this device and how they use it and how they evaluate their baby whilst on the device. And with that, I apologize for running right up to the margin of the time limit, and I hope we've got some time for questions. Thank you very much indeed.
Thank you very much, Dr. Ives. That was a great talk there, very informative, and thank you very much, Ron, as well. We've got a few questions here actually to run through. We've got 3 at the moment, but before we go on to those, I'll ask anybody, if you have any questions, feel free to put them into the question area on your screen. Please don't leave wishing you'd asked us a question. So, oh, we've got another one coming in now. What I'll do, I'll move on to the questions, and feel free to add any that you have. So, first one here from Jocelyn Morris, and this one I guess will be for Ron. Is the 24-hour trend screen likely to replace sleep studies?
Oh, I think this is a great question, but I think this is a great question for Kevin. That's definitely outside my sleep studies in neonates is definitely outside my experience range.
Thanks for bouncing.
Sorry, Kevin.
I think you can get so much information out of this. I think with a really good sleep study, you're also annotating the activity of the baby as well. You know, is the baby having a feed at this time? Is the baby asleep at this time? So if one was to use it, I'm not sure it will replace it, but you'd almost need someone alongside it annotating exactly when various events occurred, because that's the value of a very good sleep study. And obviously the sleep studies then tend to compute the percentage of time that babies are in certain ranges. I don't think it will replace it. I think it's quite a good adjunct to it. I think colleagues of mine who might be watching this in Oxford know that I'm not a great fan of multiple sleep studies in babies before they go home. And I think this might tell you when best to do a sleep study, but you're really towards the end of a baby's stay in hospital then, and I think often you're in low flow oxygen rather than on high flow, so you wouldn't be modulating it.
Thank you very much, Kevin. Next question from Lawrence Marl. I think this one will be for Ron. Ron says, very interesting, could the signal from the saturation probe not be split so that the same probe drives the OEM and the SpO2 monitor?
Excellent question, Lawrence, and one of my coffin nails over the period of the last year. Yeah, we are discussing this and thinking about this very, very frequently, and it has absolutely its positives and its risks. So having 2 probes brings you always in the situation of the old man having 2 watches. If you have 2 watches, you never know how late it is. So with 2 probes, you always risk of having 2 different SpO2 readings. And moreover, we all know how difficult it can be to place 2 SpO2 probes on those tiny little babies. On the other hand side, having a separate probe actually alerts you of a mismatch of those probes. And if you identify a mismatch, you still don't know which probe doesn't measure well, but at least you know you have a problem, and you know you need to start working on repositioning the probes and making sure that you get valid SpO2 readings. You might think, well, in manual control, I'm using 1 probe only as well. That's correct. But on the other hand side, in manual control, all reactions to SpO2 probe readings are filtered by a human's brain. The reaction to SpO2 readings on the oxygen assist module are filtered by a honestly very clever computer, but it's still a computer. So we are thinking about a solution from a technical perspective that's it's not too challenging. There is solutions for this. We are actually thinking about a solution where you could decide on a case-to-case basis, on a patient-to-patient decision, whether or not you want to use 2 probes or you want to use 1 probe. And we are thinking about something like maybe exporting the data from OAM into your monitoring system so that you can use alarms and alarm values on the values that are exported. But this is still in development and discussion, and we are definitely working on it, but it's going to take time. And we are not sure about how the solution will look like.
Thanks, Ron. Next question will be for Dr. Ives from Jocelyn Morris again. What about the incidence of ROP in babies nursed with OEM?
Right, well, that needs a large prospective randomized trial to give you that answer. Certainly, the 30 babies that we studied in the Intello2 crossover trial, that was not an outcome study. And our experience to date, yes, we have used the OAM on babies as low as 23 weeks gestation. And I'm thinking of some 24-week twins who were on the machine for 4 or 6 weeks. But even if I was to look into their ROP history, you can't interpret it. You need a prospective randomized trial for that. The big Tübingen study of over 2,000 patients will be looking at ROP, and that's providing AOC, automated oxygen control, on ventilation and CPAP. They're not using it with high flow, but that might give us an answer. Or we need a targeted trial, perhaps looking at just less than 26-week gestation babies who are on the OAM throughout the time they're on high flow. The Middlesbrough Rome study, again, not a huge study, 60 patients, 30 in each arm. We'll be looking at that, but I wonder whether that's going to be strong enough to as a secondary outcome measure to interpret. I think we need to tempt Professor Benjamin Stenson from his castle in Edinburgh to really set up a major UK trial looking at this sort of thing.
Thanks a lot. Next question for Ron from Windy Lee. She's looking for clarification. What do we mean by backup O2 when setting up the OEM before using it?
That's a great question. We both Kevin and I mentioned it, but didn't go deep into it. So a system like this needs a backup behavior. A system like this is all the decisions the Oxygen Assist module can take are based on a valid SpO2 reading. If the Oxygen Assist module doesn't receive a valid SpO2 reading, it has no bloody idea what to do. It can't see the baby. It doesn't see whether the baby is active. It doesn't see whether the baby is tachycardic. It's moving. It doesn't have any other information than a valid SpO2 reading. When the SpO2 signal is lost, the Oxygen Assist module freezes the last calculated FiO2 for 2 minutes. It's a very male behavior. It tries to ignore the problem and just hopes that it resolves by itself. When it doesn't resolve within 2 minutes, the Oxygen Assist module starts to alarm. It alerts the users that something is going on and will set the backup. So we'll set the FiO2 to a preset backup setting. The backup behavior is a little bit complicated. It's simply what the Oxygen Assist module does when it doesn't know what to do because it doesn't get an SpO2 reading.
Brilliant, thank you. Next question from Sina Kolbrenner. She starts off by saying excellent presentation, so thank you very much for that. And would you recommend monitoring CO2 in patients with the Oxygen Assist module? I guess that would be for Kevin and Ron.
We're great fans of transcutaneous CO2 monitoring in Oxford and have that available on all 16 of our intensive care spaces. Generally, we're using that in ventilated babies. I personally consider it mandatory in babies who are on high-frequency oscillatory ventilation. But we do use transcutaneous CO2 on some of our babies, for instance, a little 24-weeker, relatively unstable babies on high flows of 6, 7, or 8 liters in the first few days of life, just to make sure that they are stable. If their skin will cope with it, we will often use transcutaneous CO2. I'm not sure whether the question is then going to try and lead to challenge the research and development team to say, well, perhaps you should be feeding back transcutaneous CO2 into the machine to alter the flow rate. We've pondered on this ourselves, but I think you've got to really have a very reliable transcutaneous CO2 signal to be going down that route of technology.
Thanks a lot. We've actually got only time for 2 more questions because Ron has to run away to get his flight. So next one for Kylie Reed. Does the OEM inform you if the O2 requirement goes above a certain amount? Ron, do you want to take that one?
Oh yes, that's the FiO2 alarm limit that we were discussing. So you saw that the controller is extremely active, so we absolutely didn't want to bring another device which is alarming all the time and could force alarm fatigue. This is why the O2 alarm limit also has a delay of 2 minutes. So you can set it. You decided a baby that, for example, is on a mean FiO2 of 25%. In Kevin's unit, they would set the O2 alarm limit 10% above, which would be 35%. And as soon as your baby requires more than 35% of oxygen for more than 2 minutes, the machine will alarm. It will audibly alarm. It will tell you what is wrong. It will still further increase the FiO2. If the baby needs more FiO2, it will receive more FiO2, but the clinicians will be alerted that something is going on.
Brilliant. And last question, what is the impact on the baby in case the SpO2 signal is lost? And does the machine alarm in that case? I don't know who wants to take that one.
I can start that off, and Ron can correct me if I don't get it correct. We talked earlier about the value of having 2 saturation probes on the baby. And I noticed Ron was talking about old men wearing 2 watches. I'd like to point out that I don't wear a watch at all. I personally think it's important at this stage of the development of this technology to have the backup of the 2 saturation probes, rather than the splitter device that someone was alluding to, which has obviously been considered. If the saturation probe that is informing the OAM is lodged completely, and we found this a very rare occurrence, the device will detect this, and within 2 minutes will switch back from automatic to manual control, and will switch to the backup oxygen delivery that Ron was referring to a little while ago, either the set value or the computed value for the preceding period. So, and will alarm and let the nurse know that the baby has gone back to manual, and so will draw the nurse's attention, his or her attention, to the baby. So there is that fail safe. We found it doesn't tend to happen, but it's that is the built-in fail safe for that.
Brilliant, excellent. And on that point, we'll draw to a close this webinar. So thank you very much to the speakers, Dr. Ives and Ron Fantl. Again, another great webinar and some talks there. And thank you very much, everybody, for your attendance.